I'm really happy to have Gary Walco here today, who runs the pain service over at Seattle Children's, Director of Pain Medicine there, who's going to talk to us about advocacy for improved pain management in children. So, Gary, please go ahead.
Good day, everybody. So originally I was asked to talk about, quote, pediatric pain, unquote, which is kind of like, so what have you been doing for the past 30 years? So I took the opportunity to narrow the focus a little bit, just a little bit. So just to orient you, I kind of turned to some of the geniuses of our time for inspiration. Here are a couple of quotes by Mohandas Gandhi that I think one needs to keep in mind, that if you're trying to tackle a big job, just keep it in perspective, because you can get there. So the history here is kind of interesting in that obviously the entire field of pain medicine kind of took off a bit during the 70s. And Joe Eland, who is still working in Iowa, as part of a small study, looked at analgesic usage for surgical procedures in the same hospitals. So she identified common procedures that are done, and she looked at how pain was addressed post-operatively in adults and then matched that for pediatrics. And what she found is that children got far less analgesia than their adult counterparts, and the average amount of analgesia they got was 0. So they would go through the exact same procedures like appendectomies, etc., and have absolutely nothing. The next major event that occurred happened in the mid-1980s. Jill Lawson, who I actually spoke to a few months ago, she is a fascinating woman. But in 1985, she gave birth to Jeffrey Lawson, who was a premature neonate, and he underwent thoracic surgery, repair of his heart. And she found out after he died that he actually underwent that surgery with no anesthesia whatsoever. So they put the kid on the operating table, give a paralytic, cut into the chest, work on his heart, sew him up, send him back to the NICU without any anesthesia at all. And interestingly, that was not uncommon practice at that time. Everybody thought that the dangers of anesthesia were greater than enduring the procedure, and it was common lore that children, neonates, didn't really experience pain the same way adults do, and so it was deemed to be a reasonable thing to do. Jill Lawson took it to the press. She got the Washington Post interested in it. It went to Congress. She was quite a go-getter. And for those of you who are members of the American Pain Society, the Jeffrey Lawson Award for Advocacy in Children's Pain Management is named for her son. So that's where all of that went. Around the same time, Neil Schechter, who's also still in the field, he's at Boston Children's now, wrote a paper in Pediatric Clinics of North America where he really looked at the fact that pain is horrendously undertreated in children and started to get into why. Like, why is this the case? And essentially what it kind of boiled down to was that people believed children didn't experience pain, that you couldn't accurately assess pain in children. It was hard enough to assess pain in adults. How do you do that in people who aren't as developed intellectually and with language skills, as well as various aspects of training, and he started to make suggestions for how to change it. 2 years later, right here in Seattle, was the first International Symposium on Pediatric Pain. We just had the 10th International Symposium on Pediatric Pain that we hosted here in Seattle, so it obviously caught on. But that was the first time that people who were doing research in the area came together and sort of shared their common perspectives. One of the huge episodes was in 1987 with Sonny Anand. Sonny is now just headed to Stanford, leaving St. Jude. Sonny published a paper where he looked at survival rates in premature neonates based on their postoperative pain management. So they were all matched for the same surgical procedures. And he showed that if you manage pain postoperatively with opioids, that stress responses, metabolic responses, etc., are all far more stable and survival rates were better. Sonny actually got crucified in the press in England when this was published because they accused him of withholding opioids from the neonates who didn't get it. And the truth was, it was the exact opposite. Common practice at that point was to not use opioids. So he did use them and showed the result, but he got totally humiliated in the press. And then in 1988, the IASP formed its SIG on pain in childhood, which continues to be alive and well. So when you look at children in pain and you start to say, all right, what do we do about this? Can we educate people? Can we alert them to the dangers of untreated pain? Can we alert them to the safety of using opioids in children and other analgesics, etc.? And what you find over and over again, and this isn't unique to pain or pain in children, education is never enough to change medical practice. So if you do a grand rounds and you talk about new ways to treat something or new strategies, I think the data show that that has an impact for about 2 weeks. And then after that, people revert back to their old practices. So we have reams of studies that show that there are evidence-based guidelines out there. Most people don't read them or follow them. People, when they start to see evidence for practice, are always, well, those are all well and good, but I practice medicine my way. It's an art, not a science, all the time. So there's a lot that goes into what one would need to do in order to move this field. But clearly, didactic education is not sufficient, and what you really need is practice-based changes with rehearsal. So you teach something, you reinforce it, you give feedback on it. So I have spent a lot of my career trying to advocate for better pain management in children, and when it was clear that didactics weren't enough, I started to think of different angles one could take to make a more persuasive case. So we actually had a paper published in the New England Journal where we took it on as an ethical issue. And essentially what we said was that there's the common standard or vow that you do no harm. It doesn't necessarily mean do no hurt, because sometimes you need to hurt people in order to help them, but there is do no harm. So if you consider untreated or poorly treated pain harmful to a patient, then you would need to justify that pain being present, or else you're behaving unethically. And that was the principal focus of that work. And of course, being young and naive at that time in my career, I'm thinking, well, this will have a reverberating impact. Everybody will read this. It's the New England Journal. They'll stop behaving unethically and they'll change their practice. That did not happen. I did get a couple of phone calls from malpractice attorneys who wanted me to testify that the child experienced undue pain and suffering in this case or that case, and that therefore it was unethical practice, which I obviously didn't get involved with. So then, recognizing that that didn't work, the next thing that we did is the American Pain Society sponsored a task force on pediatric pain. And again, those of you who are into history, that task force became the first SIG of APS, and that was the SIG on pain in infants, children, and adolescents. So what we did is the American Pain Society and the American Academy of Pediatrics jointly issued the Assessment and Management of Acute Pain in Children in 2001. And again, my thought was, okay, so, when you take your child to the pediatrician, how do they know what immunization schedule to follow? Because the American Academy of Pediatrics tells them. How do they know to tell you that you should breastfeed through 1 year? Because the American Academy of Pediatrics tells them. So I'm thinking, another home run. The American Academy of Pediatrics will tell people that they need to assess and treat acute pain in children. And that didn't necessarily work. The Canadian Pain Society also launched their statement, taking what we did a step further in 2006, specifically on neonates. And policy changes do not necessarily lead to dramatic shifts. So then the next thing I said was, okay, what about the consumer? If you can't get providers to change their behavior, what if a parent goes to a pediatrician and says, you are going to use the appropriate topical anesthetic on my child before you immunize them, correct, doctor? And if the doctor says, oh no, we don't do that here, then you say, well, Dr. Smith up the street does, I'll take my business elsewhere. And so we really tried to, I tried to appeal to the consumer. So for those of you who have not heard about the Mayday Fellowship, if they ever resurrected, it's one of the best experiences I've ever had in my life. You go to Washington, D.C., and you work with communications experts, and you learn how to interact with the media and how to impact working with lawmakers, etc. So you'll see in 2005, I was one of the Mayday Fellows, and my project was educating parents on how to take a more active role in advocating for their children in pain. So what came out of that? I was on the CBS News, I was on Fox News, articles in the Star Ledger, a PBS documentary. Parents Magazine did a story on painless shots, what you need to do with your pediatrician. And believe it or not, I am in Women's World Magazine. Do you know Women's World Magazine? That's one of the ones that if you read it carefully, it's like Martian impregnates a woman in Secaucus, turn to page 6, right? But I even lowered myself to go there if we could get the word out. The other big thing that happened was, and you may or may not know the history of this, most of you will recognize the publication on the right as being the IOM report on pain in America. It started with the document on the left. And the document on the left came to be when President Obama took office and it was clear that healthcare reform was in the offing. Mayday put together a group of its former fellows, and we launched the white paper on the left, calling out a lot of the issues. It was sent to all of the people in Congress, who then in turn asked for the Institute of Medicine to do their report. So that was a rather interesting process, and obviously has paid off in some ways. We still have work to do, because this document, the Relieving Pain in America, led to the National Pain Strategy. And the National Pain Strategy draft was put out this past spring. They asked for public comment. I went through it, and there was absolutely nothing in the entire document on pediatrics. Zero, zip, nada. Certainly I thought that was quite a problem. My colleagues in geriatrics felt the same. There was absolutely nothing about the elderly, not even in the section on disparities in care. And I think that's something that I know for a fact they were overwhelmed with letters, partly because I instigated it, including a letter from the guy who chaired the IOM committee, who was a pediatrician. So it'll be interesting to see what they end up doing in terms of incorporating pediatrics into the NPS somewhere. So the other thing I got myself into that has led to some interesting impact, you may or may not have heard of the Brighton collaboration, but the Brighton collaboration is sponsored by, as you'll see on the list there, some fairly big players in the world that all look at the impact of immunization. So it's the World Health Organization, the CDC works hand in hand with Brighton, Gates Foundation, etc. And so they contacted me a number of years ago and said they wanted to study pain as an adverse event of immunization. And what they were interested in was site-related pain. So you get the injection for your favorite vaccine, and then you develop pain at the site. And so what I said to them is, if we're talking about pain related to immunization, then we're talking about pain related to immunization, not just the after effects. What about the pain of immunization itself? And at first they kind of said, you're nuts, but then they said, all right, let's do it. And so we did. And the people who got roped in, Jane Gadudu, I love her name. Jane is at the CDC, and she's the one who spearheaded this. I roped in Anna Taddeo, who is a pharmacist at Sick Kids, and Bill Zemsky in Connecticut, because all of them had done work on needle pain. And it led to the publication in Vaccine, which again then informs the Red Book and all of the other documents around the world on immunizations, now saying that you need to include addressing needle pain when you immunize. Anna has taken it to a whole new level. She has met with the World Health Organization and now has addressing needle pain incorporated into their policies. So as of literally just April or May, that got worked in. And so you say, well, what's the big deal with needle pain? Like, who really cares? And what I will say to you is it is a huge issue. If you have a child and you took them to the well-visited pediatrician, probably one of the first questions out of their mouth is, am I going to get a shot today? 10% of the adult population has severe enough fear of needles that they avoid seeking medical care. When you look at the immunization programs, like every year we're supposed to do flu shots, if you work in a hospital setting, the number one reason people refuse their annual flu shots is simply due to fear of needles. What am I missing? Okay.
We got put on hold. That's music on hold.
And that was music in the background that Randy deleted.
Thank you, sir.
Yes.
Sorry.
So at any rate, that was an area where we made some interesting inroads. The other was the brainchild of Neil Schechter again, along with Alan Finley at Dalhousie. And what Neil tried to do and is doing is putting together a group called Childkind International. And Childkind International's mission is to certify children's hospitals around the world, for their excellence in addressing pain in children. And so in 2008, there was a meeting in Bellagio, Italy. For those of you who don't know Bellagio, that's it. It was really, really painful to have to be there for a week to do this meeting. I'll just tell you a real quick aside. This over here is the conference center where we were meeting, which actually in this picture is down here. Up here is for the scholar residents. So you go to the Bellagio Institute for 28 days with a project. They put you up, they feed you, they clean your room, they do everything except your laundry. All you have to do is get there, and you work on a project. And if you're a musician, they have musical studios that are completely glass in the middle of the woods. If you're an author, they have setups, and they cross-breed in terms of people with different interests. So we had dinner one night with the scholars, and I was sitting next to the woman who runs the program, and she said, oh, we're always looking for scholars. We don't fill up. So it's like, okay, so one day I'm going to do this thing at the Bellagio Institute, and I'm telling you that so that you can think about it as well. If you've got some brainstorm for something you want to go work on for a month, all they ask is that, like if you publish a book, they ask that you give them a copy of the book for their library, but otherwise it's all paid for. So what we came up with was the Bellagio Declaration that was the cornerstone of Childkind, which basically, you could read this for yourself, but it was basically saying that we recognize that pain is everywhere in healthcare settings, that if you don't adequately treat pain in children, there are deleterious effects from that, both short and long term, not just emotional, but also physiological. You can actually alter how pain systems function irreversibly. And so it was a call for healthcare facilities to commit to developmentally appropriate intervention, assessment, and management of pain in children and adolescents. And then we spelled out the areas that a hospital would need to demonstrate its excellence for being able to get that certification. And so then, after we spelled all that out, we piloted the program in 4 different hospitals, all of which have gotten visited and certified. You'll notice Seattle Children's is one of them. And now it's being opened up to other organizations literally around the globe that are interested in showing that they've got something significant going on in terms of how they address pain. You'll be shocked to know the biggest limiting factor with Childkind is funding. You sort of need to do it in order to get other organizations to support it. And in order to get hospitals interested, you need to have the support of those organizations. So we're trying to get the World Health Organization to back it. And they're basically saying, well, go do it and then we'll back it. But it's hard to convince a hospital administrator to go through the trouble of doing the whole thing if you don't get anything concrete out of it. I sold it at Seattle Children's, and there's going to be a plaque in the lobby and all that business. So that's what they decided they would get out of it. So basically, I bring all of this to you to let you know that there is a dire need to better prevent and treat pain in children. I will tell you as an aside that I'm on a one-person mission to get rid of the term pain management. We use it all the time. I don't believe pain is something that should be managed. I think it should be prevented and treated. Managing it implies that it's okay to tolerate a certain amount, and I think that obviously that is the case clinically, but certainly the goal is to prevent and treat. I think you need a full court press to orchestrate change in medical practice. Some of it's going to be regulatory. Some of it's going to be helping people understand the value of evidence-based practice, the ethical issues, public demand, etc. I think the bottom line is that you can only orchestrate a certain amount on institutional and regulatory levels. You really need to do it on an individual level. Somewhere in our training, we lose the fundamental compassion that we come in with. Like, how could it ever be okay to hold somebody down and do something invasive to them and then walk away and think that that's part of doing business? And it happens every single day, multiple times in children's hospitals, which is a big problem. So I'll leave you with a quote from another sage and be glad to entertain questions, comments, discussions about what we could do to improve addressing pain in kids.
So, thanks, Gary. That was interesting history there. It's amazing to remember how recent it was that people thought the kids couldn't feel pain, or neonates anyway, during my professional lifetime for sure. Let me just, to stir the pot, ask you to comment on the new approval of OxyContin for those above 11 years old, and whether, in your opinion, that's a good thing or a bad thing, given what you've said.
I think it's a mixed thing. And the reason is that on the one hand, we have worked very, very hard to try to get good clinical trials for analgesics in children, both in terms of showing safety as well as efficacy. So any time that those trials are done and we get good data from them, I think that's a good thing. And any time you could be more informed rather than just using drugs off-label, I think that's a good thing. Having said that, I have some specific concerns about oxycodone and OxyContin. And the concern I have is that how those studies came to be, and full disclosure, I was on the Pediatrics Advisory Committee and consulted to Purdue while they were doing these trials, so I should make that clear. The problem that I've had all along with these trials is that you could start with adults and say, for how many chronic pain problems are opioids truly indicated? And you can answer that however you want, but whatever the answer is, the number of conditions for which it's truly indicated in children is far smaller. So many of the chronic pain conditions that you see in adults simply do not occur in kids. And basically where I think the pediatric pain community has come down is to say that opioids are indicated when you know that there's some clear nociceptive basis for the pain. So if you've got epidermolysis bullosa, if you've got osteogenesis imperfecta, if you've been treated for cancer and you've got avascular necrosis of a joint that's eroding and you're not going for surgery yet, clearly there is a stimulus for that pain. You can identify the stimulus and you can diminish that pain using opioids. And in those cases, I think it's worth considering. Where it's not worth considering are cases where it's more pervasive musculoskeletal pain, ongoing abdominal pain, etc. And so when the trials are done that lead to this approval, you basically take the adult inclusion criteria and apply them to pediatrics. And what you end up with is a phenomenally small subject pool. It's phenomenally small. Like, these studies take years and multiple institutions, because each institution provides somewhere between like 0 and 5 cases total. And so who are those cases? They're kids that have late-stage cancer, for example. They're kids that have some specific pain problem related to sickle cell disease. But they're not your garden variety, quote-unquote, chronic pain patient. My fear with this drug being approved is that the average provider out there in the world doesn't understand the populations that were used to generate those data. They see that it's FDA approved for chronic pain in younger patients, so let's use it. And so I get how it happened, I get why it happened, and if I ran the zoo, somewhere in there, the reality of how these drugs are used would factor into decisions about approving a drug, but they're not.
So there's nothing in the label to indicate the identifiable nociceptive focus that you talked about.
I have not studied the labeling that they got.
Okay, but
I can't imagine there would be.
It's a more generic chronic pain label.
I believe so, but I need to look.
Yeah, okay, me too. Any other questions for Dr. Walco? Leighton Jump, Aaron Carlson, what's the preferred topical anesthetic before injections?
There are a few. It depends on what you're trying to do. So the main ones that are used would be LMX4, which is sold over the counter. It's 4% lidocaine cream. You get depth of anesthesia down to a few millimeters, certainly far enough so that if you're going to do a venipuncture, it's up to the vein. If it's going to be an intramuscular injection, you're going to get pretty far down in the tissue. You need to leave it on for about 30 minutes. EMLA has been the one that's around for years. EMLA requires more dwell time, more like 40 to 60 minutes. You get more depth of penetration and it lasts longer. If you don't have the luxury of time, J-tips are great. So J-tips are, they use carbon dioxide and it pushes the anesthesia into the skin, so you get a small area that is anesthetized very, very quickly. Each have their own pluses and minuses in terms of side effects, in terms of cost, etc. And it all depends on the setting and where you're going to use it. But the average pediatrician's office, I think it's not far-fetched to think that when you check in at the pediatrician's office, if somebody slapped on some LMX4, and then you go through your typical pediatric assessment, you're going to have plenty of time for it to dwell, and then the needle would be essentially pain-free, except for when it hits the muscle and when the injectate goes in. You still feel that, but you don't feel that initial stick of a needle penetrating skin and going into the muscle.
Okay.
Dr. Berkman?
Yes.
Yeah, hi. A problem. Now, I do pain prevention and treatment. I like that call. I have a problem with and keep working with dosing. Now, a lot of the patients that we get in an adult population that have probably have a problem with over-opioid treatment, and it usually goes back to some childhood or frequently goes back to some previous injury. Let's say athletic accident, broken leg, they got an opioid, and all of a sudden they like the opioid, and it goes on and on and on, and finally we get them in adult pain management, and already the opioid levels are high. So I go back to, and I'm struggling with right now, dosing levels, like in a child, let's say a child is going to a dentist and has some dental issues or whatever. And there may not be a good answer for how do you figure out what opioid to use and how do you administer it and for how long when it stops. That's my question. Thank you.
Good question. So there are fairly standard dosing guidelines for opioids that are weight-based that are published very, very commonly. And I don't think that's necessarily the problem. I think the bigger problem that you allude to is who's writing these for what and over what period of time. So we've seen time and again where somebody will go to the dentist for an extraction. Realistically, you need enough opioid to cover you for 48 to 72 hours, and they're written for a 1-week supply, a 30-day supply, whatever. Similarly, with fractures, the overwhelming majority of the time, assuming that surgery is not indicated, once the fracture is set, pain goes away fairly quickly. And so the indication for longer-term opioids is extremely questionable. So I think the issue is not necessarily what the dose is, but it's why are people continuing to write for it well after it's done treating the focal pain condition. And that one is a huge problem everywhere. It's not unique to pediatrics. Does that answer your question?
That's a good start. Thank you.
Sure.